Langis Michaud as tonight's speaker. He is a diplomate of the American Academy of Optometry, a professor at the University of Montreal, and the International Relations Chair of the Scleral Lens Education Society. And tonight he will be lecturing on the topic of fitting normal corneas, the optimal use of mini scleral lenses.
Thank you very much, Dr. Lee. It's my pleasure to be with all of you tonight to talk about the new frontier in scleral lens world. I mean to fit the normal corneas. Before heading to that subject, I have to disclose honorarium and speaker fees and or research grant I receive at University of Montreal, where I practice from all the companies involved in contact lenses. So I'm fortunate to be funded by many of them, and I thank them for their support. So if we look at the principle of scleral lenses, in fact, it's not a new thinking. Leonardo da Vinci was the first to introduce the concept. Obviously, he didn't have the possibility to manufacture the lenses, but he described with high precision how theoretically we can correct human refractive error through a bowl of glass filled in water. So probably just immerse himself in a bowl of water and improve his vision. So that was one of his work that was published in 1508. And since that time, obviously, we had a lot of improvement in the manufacturing and the possibility to adapt scleral lenses, especially in the last 20 years, based on the work of Don Ezekiel in Australia, when he reintroduced, in fact, scleral lenses in the market in 1983, using gas per material for the first time to produce those big lenses and to be successful in order to correct irregular corneas or to treat eye diseases. So since that time, obviously, Ken Pullum and Ken Rosenthal, Perry Rosenthal in Boston, and other pioneers developed that technology to the point that today we consider scleral lenses as really part of the future of contact lens industry. And I say to my students at the university, if you look at your future as a practitioner, primary care provider in that modern world, you'll have to fit large diameter gas perm lenses or to find another job probably in the future. So looking at the current scleral lens applications, we all know that they are fabulous to compensate for irregular corneas. They can compensate for keratoconus. They are used to correct post-graft patients, to also compensate for pellucid marginal degeneration. They can improve vision for patients having scarring of the cornea, post-traumatic events, and or to restore the vision and the comfort after a post-refractive surgery. Corneal dystrophies are also well compensated with the use of scleral lenses, and certainly there's a lot of publications in the last years describing the benefits of scleral lenses for the treatment of dry eye, severe eye dryness, keratoconjunctival sicca, the Stevens-Johnsons, or the Sjogren syndromes. Also to restore neurotrophic corneas. There are some interesting papers published, especially by the Boston Foundation for Sight, describing patients, having improved themselves and having, reduced scarring and opacification of the cornea with the use of scleral lenses, ventilated and very large scleral lenses. After chemical burns, that's another application. So there are many known applications for diseased eye, and it's a no-brainer now that ophthalmologists and optometrists around the world are considering scleral lenses as part of their regular treatment for those diseased eye. They can help to restore vision. They can help to provide an excellent comfort. One of the main advantages of scleral lenses, optically speaking, is they are also associated with a larger optic zone, giving sharper image, reducing the high order aberrations. They have a better centration, even if we'll discuss that a little bit further in the webinar tonight. They are more stable than regular gas perm lenses, so they are probably a better alternative for many of those patients. And as to provide very good vision, they are really, really, really good. So if we compare apples with apples and oranges with oranges. So if you take scleral lenses and small gas perm lenses, I don't say that small gas perm lenses are not useful anymore. There are some very niche particular cases where you will need the small gas perm lenses, but generally speaking, if you fit patients with scleral lenses nowadays, you get an immediate comfort and a very long-term comfort. Every week at the school, I receive keratoconus patients fitted 20 years ago, 15 years ago with small gas perm lenses. They report no discomfort. They have no symptoms at all. They are really, really happy wearer. To the point that we can just consider to renew their lenses or to prescribe rigid gas perm lenses again. But if you take the time to ask the right question and to find the right answers, they are not that comfortable with their small gas perm lenses. They will complain about lens dislodge at a given time during a blink, or when they are exposed to a dry environment, or when they are in a dusty environment, some particles invade the space between the lens and the cornea, and they develop that reflex tearing that dislodge the lens. They lost lenses over the years, and so they are not that happy, I would say, even if they do not complain, because mainly they do not complain because they know that they have no other options so far to correct and compensate for their keratoconus. But as soon as you put a scleral lens on those eyes, certainly you get a wow effect, because they don't feel the lens at all, and it's an immediate rewarding phenomenon, and they endorse that technology right up front with no question. So really, at the end, frankly speaking, we can say nowadays that with the experience of what we have with scleral lenses, small gas perm lenses hurt, period. As I said, they are still useful for some niche patients, but most of the conditions, clinical conditions, where we think about fitting small gas perm lenses, certainly we can now consider scleral lenses as a valid alternative. As for visual acuity, it's the same for corneal astigmatism with a spherical lens. A small gas perm lens, in theory, we can correct and compensate up to 3 diopters, but we all know that over a 2 diopter cell value, we will create some 3:9 severe 3:9 o'clock thinning. We are so flat in the horizontal meridian that the tear flow is impinged, and we create those 2 spots of dry areas temporally and nasally. That's not happening with several lenses, with larger lenses, because we keep the cornea bathed during all the wearing time, and certainly we alleviate that physiological response of the cornea to the point that some patients develop vascularized keratitis. Dr. Libaud described that many years ago with small gas perm wearers. So we alleviate all of this, and the main factor with scleral lenses is they do not interact with the lids as well. We blink 10,000 times per day, and every time with a small gas perm lens, the lens is hurting the edges, the lids are hurting the edges of the lens, and that creates the immediate discomfort. The cornea can desensitize over time, but the lid margin is as sensitive as the cornea and never desensitize over time. So this is why small gas perm, even after 20 years of wear, are still felt by our patients. And if you put them in sclerals, you have an immediate release of that lens awareness, and you improve the journey of your patients. Learning curve to fit them and handling is certainly easier with small gas perm lenses, but these are the only benefits that small gas perm lenses have compared to scleral ones. If we compare to hybrid lenses, in some of these cases, keratoconus, irregular cornea, scars, we can consider also a post-graft, we can consider hybrid lenses, but the main difference is the presence of the fluid reservoir in scleral lenses. First of all, that fluid reservoir will help to compensate more corneal astigmatism, more corneal irregularity, and will make the vision better. compared to any kind of hybrid lenses. The second thing is that the fluid reservoir, again, keep the cornea bedded and the ocular surface well nourished by that fluid content. That's not the case with hybrid lenses. Hybrid can be really, really good lenses in some circumstances, but overall, again, sclerals are certainly preferable to hybrids in many ways. And as for piggybacks, in the past years, in the 20 past years, I fitted a lot of small gas permanent keratoconus and irregular cornea patients, and 50% of my patients ended up with piggyback system. Why? Because of the discomfort mainly, and or because I had to recenter my lens. The fitting of my lens was optimal based on the 3-point touch principles, and the fitting guides of the manufacturer. Any lenses used is different, but even state-of-the-art fitted lenses tends to be centered and center themselves at the apex of the cornea, where habitually at the apex of the cone for keratoconus patients. So it's habitually down and nasally for most of my patients. So the visual axis of the small gas perm lenses does not corresponding anymore with the visual axis of the optical axis does not correspond anymore to the visual axis. So it creates a lot of halos, a lot of high order aberrations, and we are losing some visual acuity out of that. So in some of these patients, most of these patients, I would say, we have to recenter the small gas perm lens in order to improve the vision and to alleviate the shadowing effect and the halos effect and the ghost images around the letters. And piggybacks are not really a practical solution. When we had nothing else, it worked. But patients really hate to handle two types of lenses and to have two types of care regimen. It's probably costly over time compared to any kind of, even compared to sclerals. So again, sclerals are certainly a real benefit for patients already fitted in piggyback lenses, and 99% of them will certainly decide to endorse the new technology compared to what they had before. So if scleral lenses are great for irregular corneas, can we consider them to fit on regular cornea? And that's the topic of our webinar tonight. Regular corneas and regular cornea wearers are habitually fitted with soft lenses, but we all know that soft lenses are not working as we expect. The vision and the comfort are not simply there for 40% of the patient. Survey after survey, here's one published in 2010, and still that time it was reconfirmed by many other surveys published in the scientific literature. So 50% of the patient, in the U.S., in North America at least, certainly complain about discomfort, and this is #1 reason to drop out of the contact lens market. The rate of dropout is around 18% per year. So if you fit 100 patients this year or this month, let's say that, then in a matter of 1 year from now, you will lose probably 20 of them. Around that, and it's costing a lot of money to your practice, and certainly to keep those patients in the field, in the contact lens market, would be a really good thing to benefit for the practitioners and for the patients themselves. So we have really to target those 40% of patients as the next frontier for scleral lenses and the next target for scleral lens market, because we really can improve their vision and their comfort out of that. The comfort comes from multifactorial. Many factors influence the comfort. The first published article about soft lens discomfort was published in 1969. Imagine how many improvements were made in the material of soft lenses. We got hydrogels, we got silicone hydrogels, we now have hypergels. As for the modality, we went from conventional lenses to disposable lenses, monthly, bi-weekly disposable lenses. Now we have more and more daily disposable lenses, and still we have 40% of patients suffering day after day about, soft lens discomfort. One of my favorite questions to track them, proactively track them during my examination, is to ask my patients about when they insert their lenses in the morning and when they remove their lenses during evening. And habitually, in average, it's around 13 hours per day that they are wearing their lenses. But the next question is, when would you remove your lenses if it would be possible? And habitually, they gives me the answer at 5 p.m. So that means that day after day, they really suffer from their contact lens wear for 4 to 5 hours per day. So this is why most of them do not tolerate that for more than a few months, and with no knowledge about other options, they simply just drop out from the contact lens wear. And 30 years of practice, it never happened to me that a patient called me at given evening or given morning saying, hey doc, thank you very much for your good service, but please know that I'm quitting contact lens wear from now. Never happening. I just realized that they were not wearing contact lenses anymore when they were back in my practice 3, 4, 5 years later. How you been? Where were you? Because you are a contact lens. No, I don't wear these lenses anymore. They hurt. They were not comfortable. My vision was not as good as expected, and my glasses were at the end preferable to any kind of contact lenses. They didn't ask for improvement. They didn't ask for any kind of change. And as I said, since '69, it was a regular complaint of contact lens wear, and despite the fact that materials evolve, the contact lens solutions evolve as well, the mix of new materials and new solutions didn't improve really the journey of the soft lens wearers, probably because it's multifactorial, probably because we do not fit soft lenses as we should do. But at the end, the result is the same. We have to do something better, and we have to do something different to keep those wearers in the market and in the field. And as for the vision, especially astigmatic patients and presbyopic patients are complaining about bad vision in soft lenses. As for astigmatism, it's simply optically an optical factor. If you think about soft contact lens, the optic zone of a soft lens is around 6 millimeter in average. If you have a toric design, that optic zone is reduced to 4 to 4.5 millimeter in average. So even if you have a very stable lens, toric lens, and they improved a lot in the last 20 years, but even if the best design that we have nowadays, you still are, you still have to work with that very small optic zone. Average pupil of a myopic astigmatic patient is 5 to 6 millimeter, especially overnight. So just because of that difference from the design of the lens with an optic zone of 4.5 millimeter compared to a pupil of 6 millimeter, you understand that you will create halos and glare out of that, because most of the lights entering the periphery of the pupil won't be refracted by the optical zone of the soft toric lens if the lens is kept centered in the eye, which is not happening for most of the soft lenses. If you do topography over your soft lenses, you will realize very, very soon that most of the soft lenses decenter temporarily by 0.5 millimeter, by 1/4 millimeter, but that's enough to provide a misalignment between the optical axis and the visual axis as well. And this is becoming crucial when you correct presbyopia. If you do not align properly the visual axis and the optical axis, you won't be successful. If you do not, in addition, if you do not correct properly the astigmatic component of a presbyopic patient, that's a complete failure in soft lenses, because astigmatism correction provide the crisp and sharp visual acuity that presbyopic patients are looking for. And we have not so many lenses and designs available in soft toric multifocal lenses. So this is where really I think that scleral lenses can make a huge difference. As for the comfort, scleral lenses vault over the most sensitive part of your body, which is the cornea. They do not interact with the lids, as I mentioned, so there's no lid to lens interaction during blinking, and certainly that plays a major role to improve the comfort of the patient. You maintain the ocular surface hydrated and bathed in fluid all over the wearing hours, so that provides an immediate comfort for those suffering or of eye dryness and or having instability of the tear film. With an optimal landing on the conjunctiva, the conjunctiva is not sensitive as the cornea and the lids is, so certainly if you don't create too much pressure on that conjunctiva, then you have a perfect scenario. And finally, you have no lens dehydration. Lens dehydration can create discomfort, can affect vision, can create eye order aberration. So there's no dehydration occurring with scleral lenses because there's no water content in those lenses. It's gas permeable lenses. So as for comfort, we really can improve the journey of our normal cornea patients complaining about soft lens discomfort. As I mentioned also for the vision, the optic zone is really crucial and important. The scleral lenses are most of the time well centered in front of the cornea, so the misalignment between the optical axis and the visual axis is not happening that much, exceptionally with very large scleral lenses when decentration is expected, but with smaller mini scleral lenses habitually we are quite centered in front of the visual axis, so we have better outcome out of that. We have a larger optic zone to play with, 8 to 9 millimeters. So if you have a high myope with very large pupil, again in soft lenses you'll have as 6, 5.5 millimeter, because very high myope soft lenses will have reduced optical zone. So you don't have to deal with that, and you do not interfere between the pupil size and the optical zone size. Don't create halos there, so the vision is crisper and sharper certainly. It's a gas perm material optics, and we all know that gas perm lenses provide the best vision possible compared to any kind of other soft lenses, and the fluid layer itself help to compensate any kind of irregularity of the cornea. If you look at the cornea of a soft lens wearer after a few months, after a few years, you'll see that there's some irregularities, corneal distortion, corneal warpage occurs. Even in silicone hydrogel lenses, there was one study published by a Deutsch guy 6 or 7 months ago showing that if you look at the tangential map, not the actual map that we are used regularly to fit our lenses, but if you look at the tangential map, which is the real power map used to look at the differences between pre and post fitting, then using tangential map, it showed that you create distortion with the lenses that we fit on a regular basis in soft lenses at a high level. So it's not surprising that the vision can be at a given point distorted as well, because the cornea is impacted by the fitting of those very tight silicone hydrogel lenses on the corneas. So scleral lenses can certainly help in that. So actually we have this new consensus that is developing among experts in the field and among practitioners, that we know that the regular applications of scleral lenses are irregular corneas and diseased eye, but now as an emerging trend we see more and more practitioners fitting scleral lenses for normal corneas for patients complaining about discomfort, about bad vision, more and more involved in sport activities as well. If you look at the baseball player over there in a dusty environment, the scleral lenses will really seal off the ocular surface and will protect that surface against exposure to dust and particles. It's really more comfortable. Same thing for allergy. We really reduce the allergy symptoms by providing contact lenses in general. That was proven in daily disposable lenses and monthly disposable lenses as well. But with Scleral lenses, we go a little bit further than that. Not only we reduce the allergen exposure, but we seal off the environment, and we reduce the immune system reaction based on that. So high refractive errors, as I mentioned, are certainly one target that we look for because of the large optic zone provided by the Scleral lenses. Astigmatism with a spherical lens, we can compensate up to 3.5 diopter of corneal astigmatism. That's huge with a spherical lens. So let's think about these patients struggling with non-stable toric lenses and or badly designed lenses that are not really fitting properly on those highly astigmatic cornea. Then you can really correct their vision properly and with a better optics with Scleral lenses. And again, no dehydration occurs, so there's no rotation involved, because when a soft lens dehydrates, obviously the rotation is in play, and with high level of astigmatism, that could be really dramatic. Sports activities, the Gasper materials provide UV protection. That's another benefit from Scleral lenses. As I mentioned, allergy is another potential application. For the presbyopia, again, a stable lens is crucial. That's the first condition. We have to fully compensate also the corneal astigmatism. Second really important thing to do if we want to fit with success our presbyopic patients. And presbyopic patients are marginal dry eye patients as well. We know that with aging, the tear film instability increases. The osmolarity of the tear film increase, the lid margin, the meibomian glands are producing less effective meibum, and so the lipid layer is reduced in thickness and in quality as well. So our presbyopic patients really are at the margin of developing eye dryness. With soft lenses, it's even worse because you disrupt the tear film in half and you put more instability. The presence of the lens itself on the eye can become at a given point a pro-inflammatory factor, rising the occurrence of immune system reaction, and because of that the patient discomfort is also raised. So with Scleral lenses, not only you fill in that gap and you fix those 4 problems, but also you help the marginal dry eye patients to become more comfortable, because you keep the cornea and the ocular surface bathed with no lens dehydration again, and certainly it's a better alternative for most of them. Now, we know that baby boomers are knocking at the door of our practices in order to be fitted properly. This is really an emerging market. If you look at the curves of the soft lens wearers or the contact lens wearers, there's a severe dropping out at the age of 44, 45. Most of our patients are not aware, shame on us guys, are not aware that multifocal lenses option exists, and they just realize that, okay, I can't see my computer anymore, so I just rely on glasses. So it's on us to promote new technology, especially Scleral lenses as an option, a valid option to help them to maintain their contact lens wear. Anecdotally, it's off-label usage, but I mentioned about sport. These are case reports published in Contact Lens Today, a newsletter published in 2013 in that case, and a poster presented at the GSLS in 2015 showing that Scleral lenses can be protective. In the first case, a young basketball player was poked in the eye with a finger, and the Scleral lens in fact protected the cornea from any kind of erosion related to that event. The only thing that happened was a slight conjunctival hemorrhage that resolved over a few days, and the cornea was completely unaffected because of the presence of Scleral lenses. So in sports, that can be really a key issue. The second one on the poster is talking about a teacher with keratoconus wearing Scleral lenses, and she was exposed to an electric stapler, so a foreign particle, just fly in the air and bounced back on the surface of the scleral lens, and the impact was so severe that it created a hole in the scleral lens. There was no plastic, on the cornea, but the cornea was fully protected. And if you look where the impact was, it's just right near the visual axis. So imagine that if it would have been a soft lens or no lens at all, then that cornea would have been under trauma, severe trauma, and probably would have developed scars over time, and the vision would have been reduced. So in that case, the scleral lens really protected the corneas of these two patients. So the next question is, what does it mean to switch patients from soft to scleral lenses? We have to identify a need. So as I mentioned, vision is crucial, comfort is crucial. We have to ask the right question to give the right answer, and most of my students are just, asking, how have you been with your lenses? Good, okay, next question. But, we have to go a little bit further than that. How have you been in the morning, in the evening, computer work, driving at night? Do you have any issue with comfort, any kind of dryness, discomfort under challenging environments? So let's figure out, what could be your issues, and let's resolve it, let's fix it with new technology. 87% of patients really want to learn about new technology in contact lenses when they are coming to their annual exam. I'm sad to say that the reality is that just 20% of them are just walking out of our practice with something new in their eye, or having learned something new about technology in contact lenses. Eventually, we just renew because they have no symptoms, no issue. They don't complain about anything. So we just figure out, okay, why not just prescribing again same brand of lenses, same type of lenses, even if the technology is 10 years old, no matter what. But several lenses certainly can be a breakthrough in that equation and keep the patients happier, and you as practitioners at the top edge. But before switching patients to scleral lenses, we have always to evaluate the risk and the benefit. So what are the risks? What are the benefits? There's a lot of questions that are still unknown for the long-term outcome in scleral lens wear. But when you have to correct irregular corneas, such as a keratoconus, and or to restore a condition just like severe eye dryness, certainly the benefits are very high, looking at the scleral lenses, and the risk, even if they are existing, are quite minimal, quite low. Infections are not happening that often. There are just 4 case reports published about corneal ulcers related to scleral lens wear. They were all related to extended wear scleral lenses in really particular conditions, and with patients with immune system deficiency and or medication that made them prone to infections like bacterial keratitis. So it's really rarely happening. So the benefits are really, really high, and the risk very, very low. So it's no brainer to use sclerals on those particular and those patients. But for the young baseball player at 15 years old, if you look at the future, he will wear scleral lenses for 20 years. Do we have the experience of fitting sclerals in normal corneas? Computer work is the same thing for the next 10, 15 years. Nobody has this experience, but because nobody really fitted normal corneas before with our lenses. So we have really to look at that. If there's a discomfort issue, if there's a vision issue, then the benefits are there, but we are still to pay attention to some details in order to make the risk minimal and to keep the patient on the safe side of the fence. So the limiting factors that we can encounter with scleral lenses is oxygen permeability, the corneal physiology affected by scleral lens wear. We have to respect the conjunctival anatomy. We have to deal with certain complications and to troubleshoot them in an efficient way in order to reduce the risk over time. And obviously it takes a learning curve to be efficient on that, and handling can cause some problems. It's more difficult to handle scleral lenses compared to soft lenses. You can create some corneal erosion. You can create some conjunctival pressure if you put too much pressure inserting the lenses. So there are some issues that we have to show. So let's talk about, some of them. Oxygen delivery to the cornea. You have to understand that the principle of oxygen delivery through scleral lenses goes first through scleral lens material, then tear film reservoir, and both of them are acting as resistors in series based on Irvin fat theory. So even if you have a very high decay gas permeable material in front of the eye, the weakest link of that equation is certainly the fluid layer, because the fluid has a limited oxygen delivery. The decay value of any saline or artificial tear solution is around 80. Obviously, you have to divide that permeability, the oxygen permeability, by the thickness of that tear film layer. So the higher the thickness is, the thicker the tear fluid is, obviously more impact will be created on the oxygen delivery to the cornea. At a given point, the cornea can suffer from hypoxia. We published that in 2012. It's a theoretical approach. It was confirmed by the work of Dr. James and Dr. Barry Weissman in California. There will be a new paper from that team with Dr. Campian in Spain as well, who published that in IOVS. So that theoretical model was proven valid, and we in fact took several clearance values, several decay for materials in consideration, and what we really showed is that if you look at the table here, if you can see my arrow, if you look, the highest decay material available in the market now, the Boston XO2, and around the optimum extreme are around 150. So to respect the Arvid-Bonanno or Holden-Merz criteria to alleviate hypoxia on the central cornea, then you have to produce a lens. This is the thickness of the lens with less than 250 microns of lens thickness and 200 microns of clearance. Outside of that, lens thicker than 250 microns and clearance over 200 microns will, in fact, initiate and trigger an hypoxic stress on the cornea. This is concerning only the central cornea, because clearance under the scleral lens is a wedge-shaped structure. You have less clearance over the limbus and more clearance over the central of the cornea. This is done to help to support the lens in part, and it's related to the way the lenses are designed. But in the central cornea, let's say the 5 to 6 millimeter, on the optic zone up to 8 millimeter in the central cornea, then you have this large thickness, the high thickness of the tear fluid, and obviously this is where you will create edema. That was discussed heavily in 2012. Some authors, some practitioners said, it's a theoretical model. We don't see that happening. We don't see neovascularization. We don't see microcysts in the cornea as we saw in the good old days of the hydrogel extended wear. Yes, that's true, because it's concerning only the central cornea. The limbo is free from the hypoxic stress, so there won't be neovascularization out of that, because the hypoxic stress is not there, and microcysts are visible only if you reach the level of 8 to 9% edema. Striae and folds in the descemet membrane will be visible when the hypoxia is there at a level of 12 to 15%. What the study proven, clinical study published in those papers and poster you see here, is that the central cornea is affected chronically by a 2 to 3% edema after 8 hours of scleral lens wear. And those studies were based on pachymetry. So they measure pachymetry pre-scleral lens wear and post-scleral lens wear, and they found a difference of 2 to 3%. But it's not really a good tool to evaluate hypoxia, because corneal thickness can be increased, can swell, just because the pH under the lens is changing over time, just because you have this fluid layer, the water that is present in front of the cornea for 8, 9, 12 hours. If you put your finger in a bowl of water for 8, 12, 13 hours, you will get wrinkles on the surface of the eye, and your skin will swell. So it's not surprising. The real experience, we did that and we published at the Academy in 2015. We did a really in vivo study on the cornea. We used the equivalent oxygen percentage, the EOP concept developed by Hill in the 80s. So we put probes on the cornea, and the theory under that is that if the cornea suffers from hypoxia, when you relieve the hypoxic stress, then the cells, the corneal cells at the epithelial level, will try to regain the oxygen that was missing. So the consumption of oxygen will be increased, and you can establish a curve out of that, and you can derive from computizing the numbers you find with the probes and the real oxygen consumption, and then the lack of oxygen. And what we proved, in fact, is if you take a lens, 18 millimeter Scleral lens, fitted with 200 microns of clearance here, compared to the same lens, same thickness, same fluid used, but with 400 microns clearance, then you reduce 400 micron clearance, then you reduce the percentage of oxygen at the corneal level from 9 to 6 as a reference to alleviate any kind of hypoxia. It takes you 9.9% of oxygen percentage. We have 9.07 with 200 micron. So, but look at the lens. The lens is a little bit thicker than 250 microns. So this is why we create a small amount of hypoxia here with the same thickness, but increased lens tear fluid thickness. We reduce and we drop oxygen consumption by 30%. The third less oxygen reaching the cornea. So this is a proven fact now that scleral lenses fitted thick with too much clearance lead to corneal edema. The next argument of the authors arguing against that model was that, okay, we accept that it's 2 to 3% edema, but it's certainly benign because it's really comparable to physiological edema. It's a misleading comparison because physiological edema occurs upon awakening, is not lasting for more than 1 hour. So it's not comparable to the fact that edema is triggered by large scleral lenses for all the wearing hours during 12 to 14 hours. We don't know. Nobody knows actually the long-term outcome of that hypoxic stress on the cornea. And we have options to alleviate that and to have don't have this issue if we fit lenses, scleral lenses, thinner and with less clearance, 200 clearance at the most, and this is where normal cornea patients are on the safe side. So smaller lenses can offer that because it's a mechanical effect. If you have a larger scleral lens, then you have to rely on higher clearance to support the mass of that big lens. Smaller scleral lenses, you can rely on smaller and lower clearance because you have less mass to support that lens. So arguments to fit mini scleral lenses, so 16 or 15 millimeter and lower, 16 or lower, between 15 and 16 millimeter in diameter. So you'll respect the oxygen delivery, you'll respect the corneal physiology. Optically, you'll keep the same advantage of other scleral lenses. You have less troubleshooting, and we'll see most why, because of the conjunctival anatomy. Certainly, it's easier to handle for patients, and certainly a shorter learning curve for the patients. So there are some arguments against smaller lenses. One of them is there's not enough plastic to support the lens. As I mentioned, it's a wedge-shaped tear fluid reservoir, and there is really acting to support the lens. So you don't need that much plastic in the conjunctiva at the end to support the lens. If the lens is well designed, well calibrated, made thin as possible, then you can rely on a smaller lens with lower clearance to be effective. Myth number 2, there won't be enough limbal clearance. in a well-designed small scleral lens, you'll get coverage over the limbus. You'll get limited amount of clearance, between 40 to 50 microns of clearance, but that's plenty and enough, and it provides more oxygen for the stem cells over there. But you know, understand me well. I don't say that you have. I do not accept touch. I do not accept any kind of mechanical insult over there. You have to vault over the limbus, but with a limited clearance, then we will be successful. The main advantage. Sorry, I just took some water. The main advantage of the scleral lenses, the smaller one, is you do not deal with the conjunctival toricity. We know from the work of Eve and their work that, you know, outside 15 millimeter, you have high level of conjunctival toricity, up to 3.5–4 diopter of conjunctival toricity. And this is why, from the Visser the Institute's study in Netherlands, we know that with larger scleral lenses, 90% of the scleral lenses should be fitted with toric haptics, with toric peripheries, if you want to respect a good alignment in every quadrant. If you do not align properly, you'll have an edge standoff, a compression, you'll get blanching, and you have lens distortion, and you'll get induced astigmatism. Induced astigmatism is not coming from flexure. That's a myth. Flexure is a dynamic process, and we cannot evaluate that with over-keratometry or over-topography. What's happening is that the lens will distort because it's misaligned, because it's too big on the conjunctiva. So then the lens tends to compensate for the misalignment and become distorted and create irregular astigmatism. This is why manufacturers, because they produce in mass their scleral lenses, their large scleral lenses with spherical optics, don't want to go with lenses as thin as 250 microns for the central thickness. They still produce lenses with 300, 350, and even 400 microns lens thickness, central thickness. It's too much because they don't want to get that distortion from the misalignment. If you use toric haptics, if you use lens with toric haptics, then you have a good alignment, and you can produce lenses with 250 micron thickness with no impact on the induced astigmatism. There's no distortion because you are well aligned in every quadrant. This is really crucial. But if you want to alleviate that, keep the lens at 15 millimeter or less, and then you will play with only spherical conjunctiva, and then you can use spherical optics at that time. The shape of the conjunctiva can also dictate the clearance over the cornea. That was published, you know, 20, 30 years ago. We know that most of the eye, we have all in mind that this shape should be the regular one, the normal eye that we all have in our head. But the reality is that this shape here is Mr. and Mr. Jones' eyes that we see on a regular basis. So depending on the shape of in the transition between the conjunctiva and the cornea, obviously the design of the scleral lenses should be adapted and adjusted. Another argument for smaller lenses, so if you have a big lens, a bigger lens, let's say 17, 18 millimeter diameter, then you have this higher, you know, clearance to support that lens. So the curves, the base curves from that big lens comes from very high in the sky to land on the conjunctiva, just like to have a 747 nose diving to land at an airport. If you have a reduced and smaller scleral lenses, then you bring back the ceiling of your descent from 20,000 feet to 10,000 feet because you have less mass, you have less clearance, you start from, you know, lower level, and then you land more nicely. You have less mechanical impact on the conjunctiva, less compression, less issues with conjunctival prolates, for example, and less issues in general with your landing on the conjunctiva. The mass of larger lenses is heavy, and because you are misaligned, because most of the lenses, again, are not produced with toric haptics, then the lens tends to decenter, and you lose all the advantages of the alignment from the visual haptics to the optical axis, And because of the lens tends, because of the conjunctival profile, the lens tends to go down and temporally. Then you'll get a superior nasal touch with your heavy lens, and obviously you'll create some issues as you see over there. Your tear film, your tear reservoir will be prismatic in shape, and then that will be it will be another source for induced astigmatism in your over refraction. So keeping the lens smaller will help you to recenter the lens and to make more uniform the tear fluid layer under that lens. So again, you will alleviate the factors leading to induced astigmatism. And if you are well aligned, then you will reduce high order aberration, and you'll be able to correct more properly presbyopia and high refractive errors. As for presbyopia, the basic principles is really there. You have to have a lens that is centered. This is really crucial. So larger lenses won't work as smaller lenses will work in scleral lens world, because smaller sclerals will tend to be more centered in on the ocular surface, and you'll get a better outcome out of that. The stability of the tear film should be addressed, and several lenses help you in that. The refractive and astigmatism are fully compensated with the tear reservoir. Obviously, eye dryness is also really well controlled. So let's go into troubleshooting now. The possible complication that we can have with mini or larger scleral lenses: corneal bearing. As I said, we have some concern with mini sclerals for the limbal touch, a limbal compression. So if the lens is well designed, if then you can modify the peripheral curves as needed. Then you make sure that you cover, you have enough, coverage over the limbus, 40-50 microns, and it's enough. If the large lenses are used, in some cases for disease eye, I agree, you have to use larger lenses. Pellucid marginal degeneration, you have to use larger lenses because you have to vault very low ectasia on the cornea, so you need those larger lenses. Then, but if the lens decenters, you'll get a nasal superior bearing, so you have to address that in different ways in modifying your peripheral curves, designing toric haptics. That's the way to go with larger scleral lenses. Reduce the mass of the lens to alleviate lens decentration. So ask your lab to produce lenses with 250 microns at the most as for the central thickness, and they can do it if they do a proper alignment, so toric peripheries in their design. Conjunctival compression, again, if you have a misalignment, it will happen. It's rarely occurring with mini scleral lenses, 15 or 15.5 millimeters, 16 at the most. Pinguicula pterygium, two options. You have to go smaller, really smaller, to the point to use really Gasperin. This is one case where I'm still using small Gasperin lenses. And or in some large, you can go larger with at that time to vault over the pinguicula or the pterygium. You can develop a notch, micro vault. There's that new technology with an imprint of the ocular surface and sterile lenses molded over that imprint, so that really help in those circumstances. Bled especially are really well deserved by imprint design of lenses. The tight lens syndrome, that's happening after 4 to 6 hours of wear. The lens, the sterile lens is sinking too much on the conjunctiva and create, kind of a seal off of the entire surface, and it developing a toxic soup under that sterile lens, so the immune system reacts, the eye becomes red, the lens is difficult to remove. You have to flatten the peripheries to loosen a little bit your fit over the conjunctiva. As for hypoxia, I mentioned really mini sclerals are the way to go to, especially for our normal patients, to make sure that we do not induce hypoxia on the long term, because we don't know the consequences over the long-term period. So you have to go with smaller lenses. That's the only way we have with mass production of the LADs to respect the minimal thickness and the minimal clearance. Larger lenses, it's a risk-benefit thing again. I mentioned about lens decentration, residual astigmatism as well. Conjunctival prolapse and epithelial bugging may occur in mini scleral lenses, but rarely. It's a phenomenon that we encounter most of the time with larger lenses. Again, the way to go to rid out of that and to fix those problems is certainly to go smaller. As for deposits and build-up on the surface, same potential, but deposits in the reservoir, the fogging of the reservoir is way reduced if you use smaller lenses. Two things here. I mentioned about the landing on the conjunctiva. If you have a higher mechanical impact with larger lenses, you disrupt more the transmembranial mucin and the conjunctival epithelial cells. So you'll gather lipids and mucin, and these high vaulting lenses, the big high vaulting lenses over the cornea, has a large space over the limbus, so there's a diffusion possible of those debris created by a heavy landing gathering in the reservoir and polluting the bowl. In fact, I'm still amazed that some manufacturers recommend in their fitting guide to remove the lens 3-4 times a day to replenish the bowl to rid out of the deposits. If it's, you know, if it's a case of very severe dry eye patient and we have no option, that's okay. But for Mrs. Jones, computer worker, it won't work if you want to fit her in several lenses to improve their soft lens experience. So we really have to limit the space over the limbus and to limit the mechanical impact on the conjunctiva to alleviate that reservoir pollution and the debris in the reservoir. As for handling, obviously, and no question, it's easier to handle smaller lenses compared to a larger one. As for practitioner, you have a shorter learning curve. It's way easier to fit smaller lenses because you don't have to deal with toric peripheries, misalignment, decentration. As soon as you have good corneal, good central clearance, good limbal clearance, the lens is centered, then you're done and your fit is easy. As for the fitting, exactly the same as for larger lenses. The diameter is crucial, vault over the entire cornea. The goal is to have at insertion 225, 250 microns of clearance. Smaller lenses will lose 100 microns over the day. Larger lenses will lose 80 microns over the day. So take that in account with your initial evaluation. Keep at least the lens for 30 minutes before evaluating the clearance, and then over refract spherical cylindrical. You know how to evaluate the clearance with fluorescein or without fluorescein. There are several ways to do it. OCDs can help evaluate the limbal clearance. I prefer under white light and to see some green coloration from the fluorescent here. At the follow-up, obviously, it's more difficult. In smaller lenses, if you put fluorescein outside of the lens, it will take hours to percolate inside of the bulb. So get used to evaluate under the slit lamp and or OCD. Certainly, it will help. So in conclusion, I think that it's now a consensus that for irregular, advanced, irregular, very steep corneas, very highly irregular corneas, diseased eyes, we need a larger scleral lenses, no question, and the benefits are way over the risk that we can have physiologically speaking. But for low to moderate ectasia, the keratoconus, the low to moderate keratoconus, scars, neurotrophic corneas, normal patients, presbyopic, astigmatic, patients doing sports, patients suffering from allergy, then we can consider mini-sclerals now as a real valid option to improve the outcome of our patients. So in conclusion, this is really a new era in scleral lenses. We can compensate current refractive error, especially high astigmatism, presbyopia, myopia, and certainly if you identify a problem of discomfort or vision in soft lens wearers, these are prime targets to be refitted in scleral lenses. And in order to do so successfully, you have to rely on smaller diameter scleral lenses, the mini scleral lenses between 15 and 16 millimeter. Certainly, these are the lenses to go. They provide all the benefits of scleral lenses, but with very few risks on the long-term outcome. So the train is coming for those patients. I hope that you're ready and certainly at least interested, and this is why you are here tonight. And I thank you very much for your attention. We can answer now some questions. We have a few minutes left. I'll have my screen now open to questions if anyone has one.
Great job, Langis. Thank you so much. We do have a few questions that the audience had asked. One person wanted to know, how do you fit a patient with advanced pellucid marginal degeneration where a scleral lens tends to decenter inferiorly?
That's a very good question. So pellucid marginal, as I said, the ectasia is very low in the cornea, so you have to vault over it. This is a crucial point where you have to have not 200 micron clearance, but at least 100 micron clearance at insertion, and to keep at least 50 to 60 microns at the end of the day. So if the lens decenters, it's probably because the lens, as I mentioned, again, is a large one because you have to vault over that very low ectasia. If you have a spherical optics, there's no way you'll decenter because you have a misalignment in at least one quadrant, and because of the mass of the lens will go down and temporally. This is the shape of the conjunctiva that drives the lens in that direction. So two options here. You can keep the same lens if you are good with the overall clearance that you have over the cornea and the limbus, but really look at the peripheries and design the peripheries with toric haptics, back surface toricity. Habitually, there's no good ways to measure it, except for the S3D maps. I'm working with that at the school. Actually, it's beautiful machinery. You have the eaglet that is also helping you, but you can consult with your lab. Habitually, they will give you 300 to 400 micron differences, and you can establish by trial and error how much you need, in fact, to customize your fit. The other way to go is to smaller, as I said, because you have less decentration with small, but you'll have probably an issue by vaulting over the pellucid. This is where an oblate design will help you a lot. With smaller lenses, you can overvault the entire surface, so you have enough clearance over the pellucid, and then you drop down the central clearance to alleviate more than 250 microns with an oblate design. So consult your lab. There are several options on oblate design among scleral lenses in the market, but my preference actually when the decentration is very high is to go in that direction with smaller lenses, but with an oblate design to get enough vault over the pellucid, but not too much in the central of the cornea.
Perfect. Someone else asked, for someone who is just starting to fit these type of lenses, what types of patients should they start out with just to build up their confidence and experience level?
Keep the easy one. That's my simple answer to that. Do not try to fit scleral lenses on patients where every other options failed. If you tried, let's say, the astigmatic patient, and you tried, several different designs in soft lenses, you tried hybrid lenses, nothing worked. These are not patients where scleral lenses should be at first, considered. Take the normal cornea guy, take the smaller lenses possible, 15 millimeter lenses, and then to have less troubleshooting, do 5-6 cases, boom, your confidence will be skyrocketing, and then after that you can go with more complicated cases. Learn from one technology to the other technology. I always compare to my students scleral lenses to toric lenses or multifocal lenses. You need larger and you need different design. 2-3 different designs. You have your go-to lens, and then you have your plan B and your plan C, exactly as the same thing. So habitually I prefer to work with mini scleral lenses, but then I have my larger lenses, and in mini scleral lenses I have my preferred design, my go-to lens for most of my patients. I'm really used to that design. I'm really used to how to troubleshoot the problems that lens can have. I'm really linked with the consultants and with the lab, so I'm really able to work any kind of problems I may encounter. But keep it simple at the beginning. Keep a normal cornea, keep a simple design, smaller lenses, and start with that. And as soon as your confidence is built, then move to other designs and more complicated cases.
Well, perfect. Thank you so much. That pretty much wraps it up for tonight. Have a good night, everybody.
Thank you very much for your attention. If you have any other question, you can email me. That's under my name, langis.michaud@umontreal.ca. It will be my pleasure to answer to any of your questions. Thanks, and have a good night, everybody.